Good morning, everyone, and thank you for joining the EDC Coffee Chat, Coffee with Colleen. We are really excited to have our friend and partner, Wendy Sisk, on this morning. She is just a powerhouse within the community, and we really appreciate all she does, to include coming on our coffee chat this morning to talk about what is happening at Peninsula Behavioral Health and how the changes with Medicaid will affect that organization in our community. So with that, just a few housekeeping items. We like to make sure that this is a very civil venue, and it's so nice of Wendy to come on and take time out of her very busy day to share with us. So we do require that if you have any questions, that you either put them in the chat and I will ask them on your behalf if you prefer that method, or alternatively, you can raise your hand and we will call on you so you can ask your questions. And again, we ask that you be very civil. And if someone is not, we will be sure to either mute, or if it continues, we'll remove you from the coffee chat, as is our normal policy. So thank you, Wendy, for joining us, and I will let you take it away. And if you've got some slides, you can go ahead and share them as well.
All right, good morning. I actually see a lot of really familiar names and faces out there this morning, so thanks for coming, everyone. So my name is Wendy Sisk. I'm the CEO at Peninsula Behavioral Health. And just to kind of put me into context, I moved out here to the Peninsula about 22 and a half years ago, started in an entry-level position at Peninsula Behavioral Health, spent about a decade working in intensive crisis services, providing 24-hour crisis response. Started supervising some teams, and about 9 years ago, I was moved into the CEO position. PBH has been a part of your community since 1971, when a local physician decided that, hey, there's a bunch of people who have behavioral health and developmental disabilities who have no services or supports. And so Norm Peterson conceptualized the organization, started it with 3 staff. And from there, we've grown and changed over the years and continue to try to meet the community's needs. The other thing I want to share kind of at the outset is that PBH is a little bit of a weird organization. We're part healthcare, we're part social service, and we're not for profit. And we live in this interesting economic place of being a not-for-profit healthcare provider who's also intensely into social services. And so, that creates some opportunities for us, and it also creates some challenges for us. So I guess I will share my giant slide deck, and I will try not to overdo it here. So Peninsula Behavioral Health does a lot of things for our community. We are your community behavioral health clinic. And what that means is we have a whole host of services. I have a number of community members on our volunteer board of directors. And one of the things that always comes up with our board of directors is the fact that they knew about the organization, they knew what we did, but then once they get close to us, they realize they only knew a small portion of what PBH actually offers to the community. So any chance we get to share information about what we do and why we do it, we try to take that. We do a lot of things that you would, I think, probably think that Peninsula Behavioral Health does. We provide therapy services to adults and children's. We also provide therapy services to veterans. We have some contracts with the VA to provide veteran services. We have an on-site pharmacy. We provide adult day support for folks with severe and persistent mental illness. We provide supported housing and supported employment services. We provide homeless outreach services. We provide 24/7 crisis intervention services to include implementation of the Involuntary Commitment Act. We provide housing, as I think most people know at this point, since we're involved in a really big housing project right now, but we also have some transitional housing. We are contracting with the state to provide services in an arena called forensics, which is really addressing people who are cycling in and out of the criminal justice system, who are requiring competency evaluation and restoration over and over again. So we're working with the state and with the sheriff's department to try to disrupt that pattern and to provide some additional services and supports to that high needs, high risk group that sometimes doesn't necessarily want to engage in care with us. We provide substance use disorder services, wraparound services for kids, and a whole host of other things. I think probably most people know we provide therapy and we provide psychiatric med services. But at the same time that we're doing all of that, we're trying to identify what are those other behavioral health gaps within our community. And we're continuing to assess what does that need and what more do we need to offer. One of the things that we've worked really, really hard on in the last couple of years is stabilizing our staff, so that we're seeing less transition of staff to other positions and therefore more stability for the services that we're providing. We're also working on making sure that people have ready access. On average, to get into a cardiology appointment, I think you're something like 30 days out. At Peninsula Behavioral Health, we can get folks in the same week. So, and that's for adult services or children's services. We have scheduled appointments and we have walk-in appointments available to make sure that we're providing access to all. The other thing I think that people don't realize is that we don't just serve low income or indigent people in our community. I think we're seen as the place that sees only those folks who don't have anywhere else to go. And the reality is when our community partners have clients that have needs that are more broad in scope than what they can offer, they typically refer to Peninsula Behavioral Health. And so we do offer care to folks with Medicaid, Medicare, Regents, Aetna, and most other health insurance plans. And I don't think that everyone in our community realizes that we're available to most community members. And we've made a commitment to really try to be able to provide care whether people have funding or not. And so that's really being challenged right now with some of the changes that we're seeing coming down from the state and federal government. One of the programs I always like to highlight is our outreach teams. We actually have 5 different outreach teams. We have our PATH program, which is the Project for Assistance in Transition to Homelessness, which focuses on folks with mental health needs who aren't engaged, who are not housed in our community. Our Peer Pathfinder program, which focuses on people who have substance use disorder, who are out in our community unhoused. The Real Team also has a focus on substance use with a highlight on really trying to address those folks who are struggling with opioid addiction. And then the Forensic Path and Forensic HARPS programs also do outreach to folks in our community who don't have, who aren't connected into services. And our outreach teams have over a 60% success rate in getting people who are unengaged in treatment actually into treatment. And these are often some of the people in our community who maybe have the least desire to come into care. I think that one of the complaints I hear from the community is that we don't make people come to treatment. And I also just want to be really clear, we don't have the ability to do that. You know, our services are voluntary. We provide motivational interviewing. We try to encourage people. We help them explore the consequences of not engaging in care. But at the end of the day, the vast majority of our services are voluntary services, and people have to choose to participate or not. Just like you choose to participate or not, and whether or not you go to your primary care doctor and follow up with your treatment recommendations. So these teams do enhanced coordination with some of our community partners, the community paramedic program, Serenity House. They're working closely with our partners over at Known in terms of getting people in for opioid use disorder treatment, or with the Jamestown Healing Campus. We work really closely with BART down the road from us and the Rediscovery team. So one of the really beautiful things about doing outreach services is we're never in it alone. And our outreach teams actually serve the entire county. So most of Peninsula Behavioral Health Services We go out to about the eastern boundary of Lake Crescent, and then West End Outreach Services in Forks picks up the other end of the county, as well as Western Jefferson County. But our outreach teams, our real teams, they go as far as Neah Bay and as far as Blinn. So we're really trying to serve the entire county. And our outreach teams are doing lots of creative and clever things to try to engage people, but their goal is to help people transition from being unhoused to get their treatment needs met and eventually become a productive member of our community in a way that gives them hope for their future. I also don't know that everyone realizes that PBH provides kind of a full spectrum substance use disorder treatment program. We have intensive outpatient services, recovery supports, we have adult services, and we have youth services. We've just started youth services in the last year because we saw a growing need, and our staff are really, really passionate about providing care to youth who are struggling with substance use. So we have always approached treatment from a harm reduction lens, and I want to talk about that just really briefly because this comes up. I've heard recently that PBH does harm reduction in terms of providing, drug paraphernalia and those sorts of things to community members, and that is absolutely not true. PBH does provide naloxone, as all behavioral health providers are required to provide naloxone in the state of Washington. We want to save lives. We also use harm reduction in a way that is really about not kicking people out of treatment if they're struggling, if they're relapsing. Our job is to help people explore the choices that they're making and how that's affecting their lives and their experience in our community. So again, we can't tell people you have to do it my way or the highway. Our job is to help people find their path to recovery. And that path looks really different for a lot of different people. So I just wanted to clarify that because this is something that's started cropping up recently. Harm reduction doesn't mean, hey, we're going to support your use. It just means from our standpoint, from a treatment provider standpoint, that we're going to walk alongside that journey with you and continue to help you to find your path to recovery. In the last year or so, again, we've also stepped into forensic services. So there was a lawsuit, True Blood versus the state of Washington, that really the state got in trouble because people were languishing in jail for long periods of time because they were waiting for competency evaluation and restoration at state hospitals. And this clogged up our jail system, it clogged up our behavioral health system. And so the state is now making some investments to try to disrupt that cycle with some housing supports, with some homeless outreach supports, and also we'll be starting an outpatient competency restoration program this summer, really aimed at trying to help decrease the amount of people who are cycling in and out and back through, and hopefully getting people on a path to health and recovery. So we're excited about this work. It's a new body of work for us, but many of these folks are people that we have had tangential contact with before, and this is giving us the tools and resources to actually target some of those high risk, high needs people and identify those ones that we've never had contact with, because in most cases, these are not people that we have had referrals on, that we have had contact who walked in to our front door. So that's exciting that we're able to try to provide some new supports to individuals who often consume a lot of expensive resources in our community, emergency department visits, law enforcement contacts, days in jail. None of those are good for our community, and none of those are good for those individuals. So we're really looking at how can we disrupt that constant cycle. The other thing we've done at PBH in recent years is made a really, really significant investment in training for our staff in evidence-based practices. The staff at PBH are some of the best trained clinicians in the region. We've made significant investments in evidence-based trainings like EMDR, which is eye movement desensitization and reprocessing, which is kind of the gold standard at this point for post-traumatic stress disorder. And we have trained all of our therapists in EMDR and provided them the adequate training and supervision to deploy that skill. We're doing a lot of trauma-focused cognitive behavioral therapy, dialectical behavioral therapy. We're doing some child-related specific trainings at this point. We have some staff trained in PCIT, the parent-child interaction therapy, Ruby training, which is really doing some intensive training with parents who have children with autism spectrum disorder. So we're making significant investments in making sure that our staff are qualified because again, when there are clients in our community members whose needs are too complex for other care settings, those individuals are typically being referred into the whole person care at PBH because we are one of the only places where we have psychiatric services, therapy services, case management services, peer support services, all in one place. And we want to make sure that we're able to meet those community members' needs. So at the same time that we're continuing to see more and more people coming into care, we're seeing over 3,000 people a year in our clinic. We're also trying to make sure that our staff have the tools to do that work with that complex patient population. We're not just providing individual psychotherapy, we're providing a lot of group services, and I just wanted to highlight some of our youth groups. Right now, we have groups for kids as young as 5, and we have everything from social art groups to reflective journaling. I think there was a Pokemon group for a while there. So really trying to target things kids are really into. And one of the most popular things that we do is we actually do a summer adventure group with kids. And we actually take kids out on some hikes. We get them interacting appropriately. We're modeling appropriate communication styles, distress tolerance, those sorts of things, while we're actually getting these kids out into our community to experience all the things that they might not otherwise have the opportunity to. We also have a whole host of group treatment going on in our adult group as well. But I just think it's always fun to think about the kids groups. When we built our children's center, I didn't realize how fast the entire building would be covered in glitter. But children's groups somehow always seem to involve glitter. I'm not sure how that came to pass. They didn't teach that in graduate school, but glitter is very popular amongst our kids. I also just want to highlight too that we do see kids not often, but as young as 2 or 3. And oftentimes when we're working with really young kids, we're really working with the family where the child may be the identified patient, but a lot of work that we do with children is with their families. Our WISE services also provides care not just in the context of the family, but whoever is that child's social support network. So this is our intensive wraparound with intensive services for children that includes parent peers, child peers, as well as a therapist and often a med provider. We're really trying to pull together that kids team because we know when children have a really engaged adult who provides them unconditional support, their overall lifetime outcomes are better. When kids don't feel like they have enough support, that's when we start seeing more lifelong issues arise. Kids can overcome a lot if they know they've got someone in their corner. And I just reviewed the Clallam County Health Survey yesterday at another meeting and noted that over 40% of high school students report that they don't have an adult in their life that fulfills that role. So almost 60% of our kids do, but there's a lot of kids in our community. So we're trying to help them build those relationships. And sometimes that's including community supports like their church, or there's a particular teacher at school who's a part of their cheer squad, their team. But we're trying to wrap our clinical supports to help them build natural supports that will last them through the lifetime. Because the theory is PBH should be transient in people's lives. We don't want to be the constant in people's lives. We want to pass through people's lives, give them the tools to move on.
So, Wendy,
Yep.
there's a couple questions in the chat, if I can jump in and ask
That'd be great.
before we move into housing. So Jim Hadwood asked, what is the number of people that are actively involved in substance use disorder treatment programs in Clallam County with PBH and partners, individuals, not duplicating individual services?
That's a great question, and I don't have that information at hand. I do have it, but I don't have those documents pulled up. So we do get that regional data, and PBH's substance use disorder treatment is small in comparison. We have a number of providers, right? So the Jamestown Healing Campus is serving somewhere in the neighborhood of about 150 to 200. The BART program is serving over 200. Reflections Counseling is serving, a couple hundred. I'm not sure about Cedar Grove. I haven't heard from Johnny over there for a while. So my guess is probably 800 to 1,000 people accessing substance use disorder care in the community ballpark at this point.
Great, thank you. Kristen asked, does PBH assist criminals with re-entry into the community once they are released from prison?
So that's a great question. We're actually working with the Clallam County Sheriff's Department right now on their implementation of their reentry 1115 waiver. So we have jail transitions, peer support, Jackie McCone, who's in and out of Clallam County Jail doing some of that reentry work. And we're working with the jail and being able to deliver more services in the jail while people are there. When people are coming out of prison, we're sometimes involved and we're sometimes not. So we have a program called used to be DMIO, it's ORCS, the Offender Reentry Community Program. And so we do sometimes get referrals from DOC and we start engaging people before they come out. Those referrals are few and far between. Most of the time, we don't know that somebody's coming out of incarceration until they show up at our front door. So there's an opportunity there to do more of that transition work. Generally, we get a referral if somebody has had pretty significant dangerous behaviors in our community, and they're being released back to our community. But we only get a handful of those referrals a year.
Okay, thanks. One more. Paul Gottlieb asked, juvenile criminal cases more than doubled between 2021 and 2023, according to prosecuting attorney Mark Nichols. Have you seen similar increase in mental health services needed by juveniles?
I think our numbers remain pretty consistent with juveniles. Sorry, I'm touching my computer. That said, we are hearing more from schools about distress of kids in the school setting. We're reaching out to the schools to try to improve that access to care for kids at school. So I don't have a lot of specific data on that, Paul, but it's something I could look into and see if I can see any trends over time. I think generally speaking, since 2020, we've seen a lot more anxiety and depression amongst kids, but particularly anxiety. There's a lot of research out there about youth and anxiety and how disrupted that cohort of kids was when they were, transitioning particularly from junior high into high school. Some of the younger kids, the disruption of their regular routine. We know that kids benefit from regular routine, and we've seen a lot of disruption in the last few years. So I think we're going to see some fallout from that. But what does that really look like in terms of serious mental health? We're not seeing a significant uptick in serious mental health disorders, but we are certainly seeing an uptick in anxiety.
And one more question from John. Can parents be the advance warning for an adult child coming out of prison? And if possible, who do they contact?
They would need to reach out to our access department. So, and it's tricky because again, our services are voluntary and in most cases, we require some contact from the individual who is going to be making that appointment or coming in. but there are circumstances where we'll take that information and have everything prepped and ready to go. And again, we provide walk-in intake 3 days a week. So people can walk into our office and get an intake assessment same day. So if somebody's coming out and they need that transition and that parent wants to bring their loved one in, we're happy to receive them.
Thank you.
You know, one of the statistics that we used to be really, really good at achieving in our agency was seeing people post hospital or post incarceration discharge. And after we transitioned to managed care in 2020, we don't get the level of communication any longer, and it's harder for us to track when people are coming out. So any mechanism by which we can know that people are coming back to the community and needing intensive services, we're interested in providing that sooner rather than later, because what's tragic is when somebody waits too long and starts to have symptoms and starts to slide back downhill. And we want to prevent that whenever possible. And we know that if we can see people within 7 days of release, that the likelihood that they will not return to that previous level of care improves. So we really want to capture people when they're coming out of the psychiatric hospital, when they're coming out of jail, or when they're coming out of prison.
Got it. Thank you.
All right. So a few years ago, y'all will probably remember, some of you will remember that some community providers had this kind of crazy idea to buy this little motel up on Lordson and turn it into permanent supported housing. And a group of us got together with Commissioner Johnson and tried to conceptualize this project. And ultimately, PBH was asked to take the lead on it. And we developed the Donview Court Apartments. We opened 26 units of new housing in 2023. We have 4 units of transitional housing, which are used predominantly for mental health court. We have 1 unit that's a market rate unit that we don't have any low income restrictions on, that we prioritize for a veteran veterans who have disability through their service are often over resourced for any low income housing. And then the remainder of the units are permanent supported housing for ultra low income folks. So these are typically people who have a disabling behavioral health condition. They're typically on SSI. They don't have a lot of income. They don't have a lot of resources. And we really targeted people who had not had stable permanent housing for a significant amount of time. So in the 2 years that we've been running that program, we have had 3 of our permanent units turnover. We have had, I think, 3 of the transitional units turnover as well, but we expect that those folks will come and go more quickly. But we've had 18 residents plus family members who have been in those units now for 2 years, being successful. We have very little contact with law enforcement or EMS. Predominantly, we are seeing EMS contact related to diabetic emergencies. And, you know, we've been overall very, very successful with that program. I was in a meeting yesterday and somebody said that they had driven by recently and they said saw about 5 kids circled around doing chalk drawings and just were really impressed with the sense of community that they've experienced with the Donview Court Apartments. And, you know, we've always done some transitional living. We also opened a transitional house in Sequim last year. We have 3 transitional living homes in Port Angeles. And we were asked from the time we started construction at Donview Court if we were going to do more. And our response was, we're going to have to see if we can do it and do it right. So early on, it became clear the program was a success. And so we started working on our next big project, which is the Northview project at 2nd and Oak. And we are hoping that construction will be complete. We're on track for construction to be complete in spring of next year. We're building 36 units of permanent supported housing, ranging from 2 units that will be market rate, again, earmarked for veterans who are over resourced for low income housing. About half the units will be at 30% AMI and the other half will be at 50% AMI. I suspect many of those 50% AMI units will also be occupied by people who are in that ultra low income category of 30% or below, but we wanted to create some flexibility on that. We're really excited because this was such a big investment as a community. And the amount of community support that we've received for this project has been incredibly tremendous. Colleen, you were going to say something.
Yes, so again, these are 2 bedroom units, 1 bedroom studio.
So if you look at the picture, the blue tower of that is 4 2-bedroom units. There will be 7 or 8 studios, and the remainders are 1 bedroom units.
Okay, it'll house a total of how many people?
We estimate anywhere from 45 to 60. We're really, again, for 2 bedroom units, we'll be targeting families. At Dawnview Court, we do have some small families in 1 bedroom units, a single parent and child. We've been able to help people who couldn't have their kids with them because of their unhoused status be able to reconcile with their children. And that's been incredibly rewarding for our staff who work up there and the staff who support those individuals. But we anticipate we'll have a mix of singles, couples, and families.
And so how many people are on your wait list for both Dawnview and for this project?
So we
Right.
have not opened our wait list yet for this project. For Dawnview Court, we have a wait list of about 150.
Yeah.
Our homeless outreach staff have served over 250 people so far this calendar year and have only successfully housed 28. So we know that the need is there. Um, one of the things that one of the barriers that was identified by our staff in terms of housing for some of the people that we serve is that people can't take their animals. People can't take their dogs in particular, and people will choose to live in their car and not give up their dog because that is their one constant. That's their one support. That's the one thing that helps them get through every single day. And so we're really trying to make this building built in a way that's durable. We won't have carpet in our building. We will have durable floors and things like that. So we are going to make an effort to try to be animal friendly for those individuals who don't have the ability to let go of their animal to move into housing. And I get mixed response about that. But literally sometimes people's dogs are what keeps them going. It's what keeps them alive day to day. So we're trying to do some creative things. We're really trying to build towards durability. Current evergreen sustainable development standards require us to have a full solar array on top of this building, requires us to put in an EV charger. So we'll have some modern amenities at the building, but really, our big goal is to make this building last for this community for decades to come.
Yeah, so let's talk about that a little bit more. There's been criticism that these units cost about $350,000 a unit to build. And let's talk about that. I have shared with people that yes, the community would love to build at $100,000 a unit and not necessarily have all these amenities. But if you take state funds or based on state law, if you take local funds, local government funds, then you have to meet these evergreen sustainable development standards that have been created by state law. And so
Correct.
it comes with that. It's not a choice that locally elected
Right.
officials or PBH created.
Well, and the building code and the energy code have changed significantly, and the costs associated with the new energy code are tremendous. This is actually one of the lowest cost per unit projects that was approved in this round of commerce funding. Most projects are closer to about $500,000 a unit. And so, we really are trying to be cognizant of, how do we use those dollars best? And, we really didn't feel like we could go any more than 36 units. We probably could have crammed more units on this lot, maybe saving a little bit a little bit of money to do so. But, you know, from a density standpoint, 36 units feels like a lot to ask this neighborhood to take on. And that's a lot of people to have to coordinate, especially when you're talking about folks who often have disabling behavioral health needs.
Yeah.
We have to be able to also provide the support to the people in our housing because it's not just a roof over their head, it's the services and supports that come with it that make our program successful. But yeah, the cost of building when you take state dollars, those housing trust fund dollars, you know, paying prevailing wage, those carpenters who are working over there right now, with the exception of a couple of um, apprentices, are all local carpenters, and they are making about $74 an hour. Because that's what Washington State prevailing wage for Clallam County is for residential construction. And so that's
Lower in other counties. Our county's higher than even King
King,
County.
correct.
And
Yeah. King is about 36,
yeah,
37, somewhere in that neighborhood. Yes.
it's just a ridiculous system that has been, frankly, in my opinion, bastardized by the unions, and we are harmed because of it.
And I have no control over that.
Yeah.
What it does for me is that generates an opportunity for me to have to raise more dollars because you cannot operate super low income housing like we do if you're also paying mortgage on top of it. The maintenance of the building, the staff to support the building, the staff to support the services is where the rents go. We have to be able to be sustainable, and we wouldn't be able to do a project like this if we had a significant loan that we were paying as well. We would never be able to pencil it out. And so, you know, we're reliant on donations and fundraising and grant opportunities. And I can't tell you how much time I spent writing the grants and whatnot to bring in this project to this community. But we also know that there's a significant housing shortage and people with serious behavioral health needs for most landlords are not their first choice of who they want to rent to when they have a unit open. So we've demonstrated that we can provide good, strong supports to these folks and help them be successful. And then once we have people stable in housing, we can start working with them on their education and employment goals and hopefully move people out eventually of low income housing and back into market rate housing down the road in the future. So if you haven't driven by Second and Oak, you know, it'll be worth a look-see. We'll actually start building the second floor in the next week. Our construction team, we're working with Neely Construction. They're moving right along. We had a little setback when we found an old oil tank. I don't know if anybody else on this call has ever found an old oil tank. I know Sarah Martinez did when they did the last housing authority build. It's a thing here in Port Angeles, so you know, we had a little delay around that, but things are really moving now, and we are currently slated to be in by spring of next year. We will start opening up applications and wait list probably a month or two before we think the building will be complete. It's very hard sometimes, particularly when people are unhoused, to keep track of them long term. And so we will start a new list for this project as we get a little closer. Just kind of in a nutshell, a little bit of the economic impact of PBH. So we have about 150 employees, give or take. We just recently added another 13. Our operating budget's a little more than 18 million a year. That's largely Medicaid and state funding. Over 60% of our jobs exceed the recompete expectation of $26 an hour, which I looked up just because I thought about Colleen. And we also work to inject some additional funds into our community through some of these capital projects. We've had some prevailing wage funded projects through you know, the Donview project, the Northview project, our children's build. 10 years ago, we did our crisis stabilization project. And whenever we do one of those kind of projects, we work hard to try to get as much local engagement as possible. We try when we can to make sure that we have local bidders who are coming in, and we gave extra points to local contractors using local workforce in our bid process for Northview when we scored those applications. And then we're also, providing supported employment programs to assist people in returning to the workforce. No one seems to have enough staff right now, but that could change as we as we roll into the future. So again, about 61% of our income is Medicaid. About 30% is other state contracts, and a lot of those dollars are also federal pass-through dollars, both in the Medicaid bucket and in the state bucket. We do have private insurance, rents, grants, fundraising, other smaller revenues, but really the lion's share of our revenue comes from direct healthcare services in the Medicaid sphere and other contracts that we hold with the state. So the big beautiful bill. What's going to happen? I don't know. We know that work requirements are coming, I think in 2027. We know that some Medicaid rates are being capped at Medicare rates. We also know that Medicare rates don't pay the bills, that Medicare rates don't typically cover the full cost of care in any sphere of healthcare. Most of the services, many of the services we provide aren't covered by Medicare or private insurance, so we don't know what the impact on those rates might be. The federal match for Medicaid expansion population in Washington is likely going from, I believe, 90% to 80%. So I don't know what our legislators are going to be able to do to backfill that. And we're seeing a lot of more administrative oversight and overhead. So the biggest concern for me around work requirements is people at the state level being able to process all that information, processing twice as many reporting requirements as they are right now.
So Wendy, Steve Behringer's on the call, and he doesn't know I was going to do this, but Steve, is there anything you can share from the state's perspective about how the state is going to respond regarding Medicaid reductions in the future, and what that'll mean for mental health services across the state?
Yeah, good morning, everybody. It's a challenging question in that there's different timelines on different impacts, as I think Wendy has intimated. So the work requirement kicks in a couple of years. So there's a whole, this is kind of a 10-year, projection, right? So they have different, so that's one factor that's hard to figure out. The second factor is, Washington has been all in on Medicaid expansion, right? So overall, we have about a $15 billion exposure because of, our aggressive number of waivers, and a lot of that is just the straight Medicaid reimbursement, and then about 600 million of that is sort of premium assistance within the healthcare exchange. Right now, as we speak, I mean, this week, Senate staff, House staff, the governor's staff, Healthcare Authority, and DSHS, they're all working on, trying to parse out what these impacts are. But I think it's safe to say that, currently my understanding is we're looking at about a $200 million or $2 billion setback in the current, probably, biennium. And then as these timelines kick in, there'll be more impact. But yeah, I'm not a big fan, as you would probably conclude. The work requirement, for example, as Wendy sort of talked to, is the paperwork, and the cost on the paperwork exceeds any savings. I mean, folks that have covered, look at Medicaid or even Medicare, the abuse is not by the individual. The abuse is by, the folks that are selling equipment, or different agencies that are, manipulating the system. It's not an individual. So you end up spending a lot more money than you would on actual services to require the work, to do the work requirement. And then the other thing is folks that are working don't have time to fill out the paperwork. So they end up losing their job, losing their health care, and end up, as in emergency rooms or other places where healthcare is not, not as expensive and just not preventative. So there's a lot of it that is just really problematic, but um, the state is right now, everyone, I was on a call yesterday and everyone's looking at it, trying to parse it out. So part of the challenge is the state, of course, is in kind of budget woes themselves, and we have to balance our budget. So the feds, of course, don't, and it's going to be challenging for us to backfill, hundreds of millions of dollars. So I guess stay tuned, but people are looking into it and trying to adjust as best we can.
Great. Well, thanks so much, Steve, for responding to the question with no notice. Really appreciate you and your
You
response.
get what you pay for, Colleen.
So part of what we anticipate seeing is a rise in costly services like emergency department visits, law enforcement contacts, more visits to jail, because people without insurance are less likely to take care of their needs while they're small problems. And as they escalate, they tend to cost more once the system has to respond. So we're anticipating more uncompensated care. I think across the state, we can imagine increased wait times, because if Medicaid revenues drop significantly, I'm not sure what's going to happen with staffing in services and programs. I know OMC is very concerned about, what the impact will be on rural hospitals, not just on OMC, but on Jefferson Healthcare, on Forks Community Hospital. And I think there's like 338 rural hospitals across the nation that are very concerned about their viability, because Medicaid covers at least some of the cost of care. And when you increase the number of people accessing uncompensated high cost care, it becomes crippling really fast. And Congress, in all of their wisdom, has provided a fund of about $50 million to help those 338 hospitals across the nation. So, I think that's not going to go very far.
I think it's $50 billion.
Is it 50 billion?
No.
Yeah. So, I think we have risk of seeing increased homelessness. I think we have increased risk of kids not getting their care needs met. And before I was CEO here working at PBH, my kids were on Medicaid. They were on the CHIP program, and it was a godsend. Working in a social service healthcare agency that at that time didn't pay a lot of living wages, it made a huge difference for our family. And I can see that the impacts of this change could be catastrophic. We will do our best to keep our doors open, to mitigate wait lists. I don't know how successful we'll be in terms of being able to provide quick access to care that we have today in the future as those funds continue to erode. Today, about 25% of Colleen County has Medicaid as their primary health insurance, which is down from about 30%. At the height of the pandemic, we've seen about an 18% disenrollment in Medicaid services since May of 23. And I think we're going to continue to see that number shrink. And when people do get health insurance, it's typically high deductible health plans that they're able to get through the exchange or other pathways. And oftentimes, again, people don't access care because they feel that they can't meet that deductible. And so essentially, even those people who are insured often feel as though they're not. So we work really hard to do some fundraising. That's where a lot of our fundraising dollars go, is for that uncompensated care for people who don't have access to either health insurance or have high deductibles, or their insurance won't pay for the care that they truly need, which is often common in behavioral health. So
Wendy, there's questions in the chat if now's a good time to go to them. Okay,
Yep.
so Teresa, my friend, said, how are individuals referred to the SQUIM transitional housing or other housing, Don Port permanent supported housing completed in spring 2026? How do you refer people?
So we have a housing manager, Andrew Reiners, and Andrew has an application process. Our property management is separate from our clinical teams, so he does not always have access to clinical information, but any clinician. So we require people who are in our housing to be in treatment services either with PBH or another provider. And so that provider needs to make a referral to our housing manager, Andrew, and he's the pathway into our housing.
Got it. Thank you. Next question from John Temple regarding pets. Have you worked with associations like WAG to help? I wonder if they could help house dogs for a period of time, perhaps occasional visits, and make sure the pet is healthy.
Yeah, we have done that from time to time, particularly when somebody is going to psychiatric inpatient or to substance use disorder inpatient treatment. We have worked with WAG or with Humane Society to try to temporarily house their animals. Again, for some people, that's the one thing that keeps them going, and they're not willing to permanently separate.
Paul asks, will the tenants of Northview have behavioral or mental health issues? And if so, what kind of issues?
Yep. So Peninsula Behavioral Health is a behavioral health agency, and all things for us start with behavioral health treatment. So in order to be eligible for our treatment or our housing, you have to be in behavioral health treatment services with either PBH or another provider. So I know that we have several residents up at Donview Court who are not PBH clients who receive their services at Olympic Peninsula Growth or Reflections or another program. But we require that people at the point of entry that they're working their treatment program, because for us, all things start with treatment. And so we provide care to people with lots of diagnoses. We don't discriminate on that. And so there's a huge variety. It could be a mix of people with serious substance use disorders and schizophrenia and major depressive disorder and kind of everything in between.
Got it. Okay, and Dale Jarvis has this question. My question is about funding before Medicaid cuts kick in. For several years, I analyzed behavioral health need in each of the 50 states, comparing the numbers served with estimates of how many need service. In Washington state, we were only serving about half the need, and our state was receiving less than half the funding of the better funded states. Is this the world you are still working in, and how has PBH been handling this?
Yes. So we, again, are always looking for other funding streams, particularly that are more sustainable. So all of our private insurance, Medicare revenues, those sorts of things, those go to help fund the services and programs that we need, but aren't really fully funded. Washington State is working towards an initiative to launch the Certified Community Behavioral Health Clinic of Excellence model, which has shown really great outcomes across the nation. PBH actually had a CCBHC grant for 2 years and had some really significant success. It comes with a more sustainable funding model with an enhanced federal match. So at the end of this year, Washington State will be applying to enter the demonstration for that. And we're hoping to see that over time rolled out more broadly in the state, though I think if they are successful with that we'll see a handful of clinics probably funded in the first few years, because it is additional expense at a time when the state's going to have to be figuring out how to backfill some basic services and care. Great question.
Thank you. All right. Did you have some more slides, Wendy?
No, I was pretty close to the end.
Okay.
I love you guys. I love my job. I love that my job is to support people doing really incredibly good, important work. Behavioral health is not sexy. I was in DC a couple weeks ago meeting with our federal legislators, and they all look pretty beaten up right now. There's this look of hopelessness. Not so much with Maria Cantwell. I think it just makes her a little meaner. But nobody set out to cut behavioral health. Nobody thinks we don't need our behavioral health clinics. Nobody thinks we don't need mental health and substance use treatment. I think we're just getting caught in the crossfire of a big disruption. And, we'll figure it out. We'll find a way. They say where there's a will, there's a way, and there's a lot of will at PBH. And we have a really incredible, skilled staff right now. And, I just feel like we've never provided better care than we are to this community right now. And
Well,
John,
that's
do we employ any remote employees? We do have 2 remote employees on staff at this point. One's actually a psychiatric prescriber, and the other is in our HR department. Oh, 3, and our financial controller is in Idaho. So sometimes remote staff works for us, sometimes it doesn't. There's something to be said for that personal touch in our community and developing the relationships in our community. It's part of what makes us really effective here in Clallam County compared to some other places, is that the provider network comes together and works together to make things work. And we always need more qualified staff. So I think we just created 13 new positions recently for some of those True Blood funded programs.
So Paul's question is, do most of your Medicaid recipients already work?
Some of our Medicaid recipients already work, Paul, but we also serve the severely disabled population. So we have a mix. A lot of our clients work, and we just recently did a survey, and one of the things our clients are telling us is that, hey, maybe we need more outside of business hours, office hours. So that's something over the next year that we're going to be trying to figure out how do we meet that need. Because we do have a lot of clients who are working, and we have a lot of, private insurance and Medicare clients who are working as well.
So as a mom that has had a family member that, needed PBH services, I can say firsthand about what a lifesaver their services were. And, we found a great medical provider and I just can't say enough about the services from PBH for our community. Sarah Hewling, Dr. Sarah Hewling says, too, that she appreciates the work and robust discussions I've been hearing from Wendy and others in the space. Please keep advocating for data-driven decisions making with an aim to sustainable outcomes for people to become contributing humans to society. And she also asked, how can she become a board member?
Reach out, Sarah. I'd be happy to have a chat.
Great. Well, we're just about at 9 o'clock, so I think I'm going to call it for the morning. And Lori put in a reminder, we have Lefties Night tonight. Hopefully it won't rain. And please sign up if you'd like to join us. It's free, and we've got the party deck, so it should be a fun time. Thanks, everyone, and thank you so much, Wendy, and your team.
Thank you.
St. Vincent de Paul. All right. Talk to you guys later. Bye-bye.